Good evening, all the students present here. Here today we have the topic Obstetric Emergencies Class 2, and the speaker that we have here is Dr. Neeraj Kumar, who is a Associate Professor, Anesthesiology and Critical Care, AIMS Patna. Thank you, sir. So you may start. Thank you.
Okay, thank you. I think soon many of the other means aspirants will also join. And just one disclaimer before that start, I think already has been told by Fatma also. So meanwhile, what is our plan for today's class is that we will be discussing a few important aspects of various obstetric emergencies first, and then simultaneously what I have done, I have kept few important questions there of different topics in which many of the important topics that is useful for EDIC 1 is being added here, and all these means lectures have been prepared from a standard critical care textbook like from Irwin Rippe, and few of the things has been taken from the from your journals as well. But before starting this class, I just want to request you all the students, that please don't unmute your mic and don't try to disturb the class, because it is very important. Many of you have paid for this, and I'm sure that it will be of much use. And meanwhile, what I have kept, that I have kept few questions like type K question and type A questions in between, so that you all can answer. But while answering, you can use the chat box for typing either true or false statement, or which answer is means you feel that which answer is correct for type A questions. Okay. So what I feel that this will be small instructions for you all. And I hope that at the end, if you have any problem, then I have shared my email ID as well as my X account ID, so that if you have any issues regarding today's class, you can discuss me on that. Or meanwhile, we can discuss in between also if you have any problem. Okay. So you can straight away, you can ask the questions in the chat box. So we all are aware about this obstetric emergencies, and it is one of the most important topic that has been very frequently asked in EDIC 1 examination. And why these obstetric emergencies are important, because we always feel that there are fixed number of topics which is especially reserved for the obstetric emergencies, right? So many of these topics, like you will feel that what will be the obstetric causes and what will be the non-obstetric causes for these emergencies. So I will tell you that how these causes are important, and what things that we have to remember for your upcoming exam. So now coming to the first part is, before that, I just also want to tell you that I will be going to cover the obstetric emergencies, like various parts of obstetric emergencies. I have added trauma and pregnancy also. What is the consequences of trauma over a pregnant patients, and how you are going to manage those patients. And then after that, few aspects about your hemorrhagic problems in the pregnancy. Especially, I will deal about the postpartum hemorrhage. Few important things related to your physiological changes of pregnancy. One diagram I will discuss, and then after that, I think a few important like amniotic fluid embolism, like your peripartum cardiomyopathy, and then at the and few other like your in which important means I have omitted that infection and pregnancy part, because what I feel that it is of not much of use, but yes, definitely you have to read all those things. Now coming to the first important thing, that why these obstetric emergencies. Now we all know till this point of time that these pregnant and postpartum women, who are those patients who requires these ICU admissions? Basically, if you'll understand or if you'll see that only 1% of the all pregnancies and less than 1% of the all ICU admission, it means only 1% of the all pregnant patients requires the ICU admissions. So you just think of this percentage, that is, it is very low. However, it is very low for as a incidence wise, but for you all guys, the questions are very important. And if you'll ask me that what will the primary cause of these admissions, so the primary cause is obstetric conditions rather than unrelated medical complications. That's why many of these patients or many of these women are having these problems in the postpartum period. But exceptions is trauma and cardiomyopathy, which doesn't happens in the postpartum period. It can happens in the any part of the in the pregnancy interval. Now, coming to the next aspect is that the one studies has been also suggested that these SOFA score is one of the better system for predicting mortality in obstetric patients. So, if you have been asked about that, which is one of the scoring system for assessing the mortality in obstetric patient, so you can mark one of the answer like SOFA. So, SOFA is one of the option for predicting the mortality, especially in obstetric patient. Maybe you'll get an indirect question or of some fact based questions in which it may be written somewhere. Now, the second part is the actual mortality rate is mainly depend on the disorders that has caused that patient for that ICU admission. It is not that the mortality is dependent on directly some other factors. It is basically dependent on the disorders. There are various disorders which we will learn. Now, this is one of the study which has been published in Hong Kong Medicine Journal in 2010. And what they have done, they have basically gathered the information of clinical characteristics and their obstetric patients' outcome. Those patients who have admitted inside the ICU or admission inside the ICU, and they have done a 10 years of retrospective study. So it was a good number of patients were there. So you can see that this is the total deliveries, means 37,500 deliveries, and this is the total ICU admissions out of these 10 years, like from retrospective from 1998 to 2007. And out of these 7692 patients, 50 patients were admitted because of the obstetric conditions, and these 50 patients, obstetric patients, were admitted inside the Pamela Nethersole Eastern Hospital. Okay. Now you see that how these incidents is going to get changed. Now they plotted another findings that out of these 50, 35 where the patient admitted inside the ICU is because of the obstetric causes, and rest 15 patients were having the ICU admissions because of the non-obstetric causes. So out of which now you see this PPH is topping the list. So it means that PPH is one of the most important complications which is associated for the obstetric ICU admissions. If you look for the other causes, PIH is another cause in which around 7% of the patient underwent a PIH in these 50. Means out of these 7605 patients, 50 patients were obstetric, and these 35 patients were having these pregnancy-induced hypertension. And these pregnancy-induced hypertension, three findings were there. Few of the patients admitted because of the HELP, few of them admitted because of severe eclampsia, preeclampsia, and then few of the patients admitted because of the eclampsia. It means we have to know PPH, we have to understand the physiology of PIH like eclampsia, then severe preeclampsia and HELP. So I will discuss this two part. And then third part was 6% patient got admitted because of the amniotic fluid embolism. So I feel that's why I have added AFE also as a part. Ruptured ectopic pregnancy, I have not added, but I have definitely added 2% of the causes like peripartum cardiomyopathy. Few things sepsis related pregnancy that you have to read on your own, because in this duration of time it is difficult, almost impossible to cover the all topics. But yes, a few of the important thing has been added here. Now coming to the next part, that what will be the non-obstetric causes. So sepsis is the non-obstetric causes which is covering around 7% of the patient, which includes the sepsis, may UTI, and then chest infection. Few of the cardiac related problems were also there, and then some CNS related like encephalitis, meningitis. So this is about in nutshell about this retrospective study. Then why the importance of obstetric ICU admissions, and if obstetric ICU admissions is there, what will be the obstetric causes and what will be the non-obstetric causes, that you will keep in your mind. Okay? Now the next point is how will you clinically evaluate? How will you clinically evaluate the Okay, so how will you clinically evaluate the gestational age? So again, this is important question that may be asked as a STEM. If you'll pass EDIC 1, you may get a STEM questions in which they can ask that how will you clinically evaluate the gestational age. Now, for evaluating gestational age, it is always important that you need to remember the three basic methods that has to be used for the measurement of gestational age. What are the three basic methods? That is very simple. You obtain a clinical history or your menstrual history, then you perform a clinical examination, and third, you do ultrasonography. Now, first day of the last menstrual period is required for the calculation of an expected date of delivery according to Nagel's rules. We all know that. So add 9 months plus 7 days of last menstrual period. So by which you can calculate the total number or expected date of delivery of using this Nagel's equation or Nagel's rule. Now coming to the next part, that is your clinical examination. So how can you do that clinical examination? So by knowing the size of the uterus. And how will you assess this size of the uterus? By clinically measuring the length from the symphysis to fundal height, which is the best but a crude methods of estimation of gestational age. So what it means? It means if you're going to see doing the clinical examination at 20 weeks of pregnancy, the fundal height should be how much? It should be 20 plus minus 2 centimeters. So it may be either 18 centimeter or 22 centimeter above the symphysis. So approximately which corresponds at the level of umbilicus. So this is another part that for doing that clinical examination. And first part is for obtaining the menstrual history, for knowing the estimated date of delivery or expected date of delivery. Now third part is the ultrasonography. It is one of the most accurate. That the second one was most crude, but it was most accurate method of estimating gestational age. So what are the factors which is going to make these G assessment or gestational age assessment very, very difficult? So if the patient, if the mother is having a multiple pregnancy, if his baby is very big, like fetal macrosomia is there, or if more amount of amniotic fluid has been collected, like polyhydramnios is there, or if the patient is having a features of uterine fibroids. So these questions may be asked in your examination, that what are the factors which makes the assessment of GA assessment difficult, especially on obtaining ultrasonography. So these are the few findings where you may be having a difficulty. Now coming to the next part. So what are the methods that are available to facilitate the uterine displacement? So again, this question is again, they can ask this question, that what are the methods that is available for facilitating the uterine displacement? Because we know that because of the increasing gravid size of the gravid uterus, it may causes your supine hypotension syndrome, or this because of the large size of gravid uterus, it compresses your IVC, leading to the problem. So that's why what are the various method to facilitate this uterine displacement? So in the operating room, so if you are dealing this patient or pregnant patient inside the operating room, a lateral tilt can be applied on the table, right? So this is one of the point where you can apply lateral tilt to the table. Why? Because you have to aim, you have to keep this degree around 15 to 13 degree tilt to the left side. So when you will tilt to the left, the gravid uterus, because of that gravity, it will not push, or it will not compress the IVC. Second part, you can put a double up pillow, and that can be placed on the patient right hip. You can absolutely keep over the patient right hip to facilitate the inclination to the left. So if you elevate the right hip, the inclination to the left will be automatically there. And third part is your MUD, that is your maternal uterine displacement. So how are you going to do that? How are you going to do maternal uterine so Salal, can you mute your mic, please? Don't try to disturb the class, please. So if you have you can have this manual uterine displacement as well by lifting the uterus. How you lift the uterus? By utilizing your two hands or two hand kephalad, and to the left can be performed. So in this diagram you can see that how these two hands has been used, and this has been this lateral uterine displacement is been applied to this patient only for preventing this supine hypertension syndrome. So these are the methods that can be used or that can be utilized while you are attempting a STEM type questions. Now coming to the next part. So now this is again very important part, that what are the one or two questions will be there from the physiological and physical changes of the pregnancy. I have added few important things, but for your understanding, you go and read definitely. So I have divided into three parts. So what are the parameters that I would look for? What are the anatomical and physiological changes, and how it is going to impact your resuscitation? If you're planning to ongoing resuscitate this patient, so what will be the major problem? So we'll start with upper airway. So upper airway, we all know that these patients have a increased hypervascularity or increased mucosal edema. That's why the difficult airway algorithm has to be in place, and a smaller size of ET tube has to be used. So this is very, very simple. Everyone knows that. Everyone knows that. For diaphragm, this diaphragm is splinted. Basically, the diaphragm is splinting of the diaphragm will be there because of the gravity uterus. And what it will do, again, we all know that because of this splinting, the patient will have a decreased FRC. That's why, because if the FRC is decreased, the patient will have a more prone of hypoxia, or more if you have increased the apneic period, or if your apnea will increase, the patient will have more problem, because already the FRC is compromised. That's why the rapid desaturation happens in these kinds of patient, especially when the splinting will be more because of the more increase in the gravid uterus size. The first point. Second important, that these patients have generally reduced mortality, and they have increased gastric pressure. Intragastric pressure is increased, so they have increased risk of either GERD or aspiration. Now coming to the physiological changes, which they used to ask in the exam, that what will the affect, how much changes in the minute ventilation will be there. So this minute ventilation will increase approximately close to 45 to 50% of the patients. So normally from the baseline, 45% increase in minute ventilation will be there. So if minute ventilation will increase, what will happen? The PaCO2 in the blood will be not retained. The PaCO2 will be slowly going to get decreased, and that's why the patient will have a decreased buffering capacity. And so if these buffering capacity is going to get affected, so what will be happen? The chances for acidosis in these groups of patients will be more, because the buffering ability of the body will be compromised. That's why the acidosis will be more. And the second point, the oxygen consumption of the in these groups of patients is generally increasing by 20%. Okay, so why? That's why the hypoxia is more likely, or the second cause is because of that decreased FRC. So these are the two important cause why the hypoxia will be there. And if you look for these, how much decrease in FRC, so it is around 25% decrease in FRC. That's why these patients develop hypoxia, but earlier hypoxia. And then comes considering to the chest wall compliance, what will happen to the compliance? Decrease secondary to the uterus, and then displacing the diaphragm cephalad, making a diaphragm in a splinting position. So what it will do, it will decrease the transalveolar pressure. So your transalveolar pressure will going to get compromised. Now coming to the next part, that what will be the next important thing, that if you look for this part, so here again the important aspect is on your yeah, on your plasma volume. So what will be effect on plasma volume? Plasma volume will increase by 50%. So what it will do? It will produce a dilutional anemia effect, which we all know. The oxygen carrying capacity of the blood will decrease, which we have discussed. That's why these patients have enhanced physiological reserve against the hemorrhage. So if the hemorrhage will be ongoing, the physiological reserve is more. That's why the God has made the physiology like this, so that if something goes wrong to this patient, the physiology comes into action, and then that's why the plasma volume is increased, only to combat the hemorrhage process that has been started. If it has been started to into a pregnant patient, how these plasma volume is going to play a role. And now the second point is heart rate. This heart rate is going to increase by 15 to 20 beats per minute. Cardiac output is going to increase by 40%. So now the chest compressions during CPR likely to be less effective as demand is higher. That's why the cardiac output is very, very much compromised here, and the cardiac output is going to increase by 40%. That's why chest compressions may be less likely effective if you are doing in CPR. Now come to the arterial blood pressure. Arterial blood pressure is falling by 10 to 15%, and that's why the physiological reserve will decrease here. Now coming to the uterine blood flow, so it accounts for around 10% of the cardiac output at term, and it is potential for your massive blood loss. Coming to the cardiac anatomy, we know that this heart is rotated more cephalad and to the left, and that's why the next part is the chamber size will increase, particularly the left atrium chamber will increase more, and that's why these patients are more prone for dysarrhythmia and SVT. Okay.